For those of you that are coming back, you already know who I am. For those of you that are new, welcome to all. My name is Dr. Nik. I'm a pediatric dentist, board certified in Canada and in the US. I completed my dental school at McGill University and then went on to do a general practice residency at McGill's Montreal Children's Hospital site. I then went on to specialize in pediatric dentistry at Eastman Institute for Oral Health in Rochester, New York. Upon completion of that residency in pediatrics, I went back to Montreal and took over the McGill GPR program director at the Montreal Children's Hospital, which is where I completed my own GPR training a few years prior. I got to train residents that are new graduate dentists. So the academic component was huge. I got to do some operating room, hospital dentistry, on-call, and emergency dentistry as well. This was a part-time position, so I did practice in a pediatric office privately as well. Last year, just under a year ago, I moved to Toronto and became a pediatric dentist at the Apple Tree Dental for Kids. I also became the clinical coordinator there. So our clinic locations currently are in Newmarket, Stony Creek, North York, as well as Don Mills in North York. Our team consists of pediatric dentists as well as general dentists that have all received some form of training in treating children. You can refer to us online. The services we offer, there's a variety of services. We do offer tongue and lip tie treatment as well. We offer caries risk assessment programs, infant oral care programs, as well as desensitization visits for patients with special needs. Our in-office sedation is quite asked for or referred for. Nitrous and oral sedation are sedations that we offer to patients, as well as in-office general anesthesia. The in-office general anesthesia is provided by an anesthesia team, which involves an anesthesiologist as well as their nurses, and then the dentistry is done by the dentist as well as our assistants. As you all know, we're all closed for elective dental services. However, we are offering teledentistry services for virtual consultations and then as needed in-office treatment for dental emergencies. So if you'd like to refer us patients, the phone number is listed right there. I will give the email at the end of the presentation as well with the phone number and the address. Otherwise, the patient can simply log into our website and book a virtual consultation. And then depending on what they need, we will guide them towards the emergency treatment in our Don Mills clinic. So that was my little intro. Welcome everyone and thank you for joining, and we will continue to do this on a weekly basis, trying to come up with different pediatric topics. So if you do have questions, concern, feedback, please do use the survey that we mailed out to you, or just simply email at webinars@appletreedentalforkids.com. I check all those emails, so I'll take your feedback and I'll try to shape the webinars so that they're more beneficial for you all. Dental traumas are today's topic. Dental traumas are scary. And one thing that I've learned is parents come in and they expect the dentist to be able to help them and manage them. And as dentists, we should be able to manage oral trauma, especially in our pediatric patients. However, it's not the easiest for us and it's not the easiest for the parents. So it's always important to remember that these times are very scary for the parents. They might be frustrated, they might be emotional, they might be scared. So there's a lot of emotions that are up in there. And when they do come in, you will learn to manage them, manage the parents, as well as manage the trauma, and they will always remember you for this. So what I've learned is through the hospital dentistry that I did, all the traumas that we saw, those were the most thankful parents at the follow-ups and the future visits. They became our patients. They became, our new patients, then became our recall patients. And they were always thankful and they always remembered the care that was provided during the trauma visit. So they will definitely appreciate you for this. So do the best that you can in the management of trauma. And sometimes it's management plus educating the parents on this issue of trauma. So this is the part one, which will cover primary dentition. But before we get into that, I want to share some facts about trauma in children. In primary dentition, the highest incidence of oral trauma occurs between the ages of 2 and 3 years old. In permanent dentition, traumas usually occur between 9 and 11. However, the range is variable. And they usually occur following falls, motor vehicle accidents, violence, and sports. So this is for the older kids. However, for the young children, falls are the most common, and sports and physical activities are the most common for the older children. It kind of makes sense because the younger children begin to walk a lot and play a lot at the age of about 2 to 3, their coordination is still not at its highest and therefore more likely to fall with toys in their mouth or playing with other siblings and falling. So that makes sense with the young children. Remember also that higher risks of trauma are associated with certain medical conditions as well as specific dental conditions. So that means patients with cerebral palsy are more likely to experience at some point in their life dental trauma or oral trauma. Similarly, those with excessive overjet are more likely to receive a risk of dental trauma as well. One more tip, dental traumas are never just associated with one type of injury. So remember, every time you look at a dental trauma, don't stop once you've made one diagnosis for that tooth. There might be more than one tooth, first of all, and second of all, multiple injuries might occur on the same tooth. So keep that in mind. But before we even get into the dental management and dental evaluation, there is a lot of checklists that I go through in my head. And the first things I look at is the priority in trauma examination. So every trauma that I get, no matter how minor it seems, I always assess loss of consciousness, excessive bleeding from any part of the body, head, neck, and spinal injuries. Those are my 3 things that would tell me these are priority. If any of these are present, I would be referring them to the emergency. Dental can wait. You could lose a tooth, yes, possibly by waiting, but the loss of consciousness, uncontrolled bleeding, head and neck, spinal injuries, those 101% win in priority and should be addressed first. Once that has been ruled out, my next checklist is to start gathering information. I always want to make sure that the source of information is a reliable source. So the person that is telling me this is either a caregiver, guardian, parent. It's not an older sibling. It's also not someone under the influence. So I want to make sure that the history that I'm getting is the most appropriate. I'm going to ask cause and history of the injury. So first, I want to know how was the injury and what was the injury. So I want to know what happened and how it happened. So what happened simply will tell me kind of where to look at. So if a patient comes in and says, I fell during skiing, and they hit their chin on the ground, I'm going to think, okay, they hit their chin. I'm going to evaluate the frontal area of the dentition, so the anterior area, as well as the chin and the bone in that area. However, I know that any injury that hits me like this will hit my condyles as well and may hit my posterior teeth as well. So I'm not going to focus myself just on this. And that's why what type of injury and what was going on during the injury is going to be really important. How is important for story. So I want to know how it happened. I want to know what was going on, what was the injury manner, and pretty much how the patient got to this state. This becomes important not only for assessment of the dentition later, but also to rule out child abuse. So as much of us, we may not hope for any one of our patients to undergo child abuse. It is more common than we think. And therefore, ruling out child abuse is part of our role. So if you do detect or suspect child abuse, you are required to report this, especially for pediatric patients. So what I always do is I always want to make sure that what I see will connect with what the story was. So the form of injury, how it happened, does it make sense with what I'm seeing as the findings? And if it doesn't, that's where I'm becoming more suspicious. When the injury happened and where the injury happened are more specific to what your management is going to be. So when timing becomes really important for pulp exposures as well as avulsions, and you'll see later on. Where the injury happened really decides contamination, whether I'm going to be needing antibiotics later, whether I'm going to be looking for tetanus related questions. So that's where the where will come into play. Once you've gathered all this injury-related information, I go on to my general assessment, medical, dental, and social history. I start off with then an extraoral examination, okay? Followed with then moving into the mouth, looking at all the soft tissues, lacerations, inside, outside of the mouth, but mainly the cheeks on the inside, the floor of the mouth, the tongue, and then the inside of the lips. And then I move on to my intraoral hard tissue, which involves the jaw bones as well as the teeth. The reason why the extraoral evaluation is important because a lot of the times these injuries are related to falls or sports or motor vehicle accidents. So there's more likely that it's not just the teeth. However, as a dentist, our focus usually is oh, that front tooth is broken. However, we don't want to stop there. We want to assess everything. And I always start with the outside assessment. So I have the patient sitting in front of me. I will do my visual inspection, and then I will also do my contact tactile evaluation. I will touch around the eyes gently to look for any fractures. I will look for any bruising around the eyes that is unusual, the steps in the bridge of the nose, as well as any bleeding from the nose, any zygoma fractures, as well as any maxilla-mandibular fractures on the outside. You can look for any hematoma behind the ear. You can also look for any neck injuries at the same time if you missed it priorly. What you want to also look out for is if any of these injuries go with child abuse. Okay, so that's why I put that last picture there. You always want to rule out child abuse. So it's not just for your data collection that you're doing this. You're doing this for obviously management, but also to make sure there's no child abuse involved. Then finally, after doing all that, we finally get to the teeth, and that's the important matter that you're here for today. So we'll go over primary dentition injuries today. These injuries are divided into fracture and displacement. However, I did not write fracture or displacement injuries. I wrote and, because every dental trauma should be evaluated for and could be possibly associated with more than one type of injury to the tooth. So even though you may not see it, you have to do your full evaluation, whether it's radiographically or clinically, to make sure there's no other injury. And I always go in with the mindset that there's more than one injury to that tooth. This way, I'm making sure that I don't miss out on anything. So crown fractures is the first type of injury, and these can be right away divided into three categories: enamel fracture, enamel dentin, and pulp exposure. The fracture could be either a complete chip and loss of fragment, or it could be a crack present in the tooth. This fracture, when it involves just the enamel, is that first type of category. When it goes deep into the enamel dentin area, this is known as the dentinal fracture. And then finally, when the fracture is so deep that it exposes the pulp, we have now a pulpal fracture or a complicated fracture. So what do they look like? Here are the enamel and dentin fractures. So on the left side, we can see the enamel fracture where we've lost the fragments, and this is on multiple teeth. Definitely these are fractures because you can see little rigid edges. However, there is also a condition known as Hutchinson incisors, which may appear with notched incisal edges. However, this we can see that they're a little bit more rugged at the edges, so it's most likely due to trauma. And now it only involves the enamel. So this is our first type of fracture, which is the enamel fracture. When it goes a little bit deeper and has spread into the dentin, it's now known as an enamel dentin fracture. Again, here we have little enamel chips. Those look normal malmons. So those are the first two types of fractures, and that's what they look like clinically. Their management is pretty straightforward in the primary dentition. So what I normally do is when I get an enamel fracture, I will right away, obviously, take a radiograph. And the reason why I'm taking the radiograph is I'm making sure that I rule out any other injuries, so displacement injuries, as well as any root fractures or crown root fractures and bone fractures that we'll see later on in this presentation. Then I ask for symptoms. Usually enamel fractures are asymptomatic, other than the fact that when the child rubs their tongue over that fracture site, they might feel some sharp edges. So I will consider smoothing the edges. Usually the enamel fractures are so small that even if the parent asks, hey, can you build this back up? If it is possible and looks like the prognosis could be good, I have done it in the past, but I've also seen that the parents come back and then the chip composite is gone. Remember that cooperation will be a huge factor in deciding whether I do any buildups or any resin restorations following fractures. Otherwise, simply I smooth the edges. You could put a liner if you have room for a glass ionomer liner to just make it more smooth, and then continue your follow-up. In terms of fracture follow-ups, I usually, for these two, since they're not that significant in terms of injury, I usually monitor them probably a follow-up in about 7 to 10 days, decide whether I'm doing the build-up or not at that point, and then finally probably do another follow-up in a month, and then at recall. In terms of resin buildup, so a lot of dentists ask, why not do it the same day? I generally don't do them the same day, even if the parent really wants to, even if the child is asymptomatic, or if the dentist really wants to. I don't really recommend it. And the reason why is that tooth just experienced a trauma, it experienced an injury, it's sensitive. Taking a burr to bevel, taking the drill vibrations to a tooth that's sensitive might be more sensitive to the child, first of all, and you may lose cooperation. Second of all, you're also stimulating the pulp as well as the tooth after it just experienced an injury. So it may have just had an enamel fracture, but there may have also been a concussion injury, a subluxation injury. So you want to rule out those before you take a handpiece to a tooth, but also it's probably better just to do it at the follow-up. They're going to be coming back in about 10 days. You can do a follow-up as well as add the resin that you need to. The differentiation between a dentinal fracture is that there will be a little bit more sensitivity. So not only is it a bigger clinical fracture, but also there is more likelihood of sensitivity to cold and hot, as well as the sharpness on the tongue. I still take a radiograph to rule out all other dental injuries related to this tooth, and then I either smooth the edges and put a sedative dressing or simply put a sedative dressing. I do inform the parents that the sedative dressing may pop off, but we'll be seeing you in about 10 days, and then we'll take it from there, whether we're doing the buildup or not. And the follow-up will be carried out in about 10 days, future follow-up in about a month, and then after that, it could be at recall. Now we get to a little bit more of a complicated fracture. So this is actually called a complicated fracture. It's when you have a pulp exposure. So now the fracture has spread from the enamel, dentin, and down to the pulp. And the pulp exposure could be of different types. This is an example of a very small pulp exposure. I've seen pulp exposures completely open. I've seen pulp exposure where you have just one of the horns exposed. So there are different exposure types. There is also different levels of contamination of the exposure, and then finally the timing of the exposure, the duration. Those all fall under the exposure type. That's one thing I consider as a whole, and then I consider the cooperation when deciding what treatment. So these patients, when they walk in, obviously I'll take a radiograph right away. We'll rule out any other injuries, any other teeth involved, any other injuries to this specific tooth. And now I see my exposure. So when I see my exposure, I'll ask questions of how long ago did this fracture occur and start, debating how long this exposure has really been exposed to food, the external environment, to water, juices, all those kind of things. And then I also look at the size of the exposure. Then finally, I look at cooperation. And if I think I can do a treatment on this child, in terms of pulp treatment, then I have two pathways. If I cannot, so we'll start with the extraction pathway first. If obviously cooperation is poor, or a really young child, and a pulp treatment will be very difficult. At that point, I'm leaning towards the extraction because prognosis in general for this tooth without any treatment is not great. So it's either going towards pulp or extract. It's not just leave alone and monitor or put a glass ionomer and monitor. No. So if it's a long exposure, so let's say it's been about 2-3 days, it's dirty, it's contaminated, it's a large exposure, there's poor cooperation, then I'm leaning towards the extraction route. However, if it's a minimal exposure, I have some cooperation, it hasn't been more than 48 hours, it looks clean-ish, what I will head towards is the pulp treatment. Again, for this, the deciding factor is going to be cooperation for me. All right, so what we'll do first is we'll take that radiograph, rule out any other injury, and I'll take a sodium hypochlorite with a cotton pellet and simply clean the area. Once I've cleaned the area,
1400. Yeah.
I'm just gonna get back in. Someone mute themselves, please. Oh, there we go. Perfect.
It's if it was a withdrawal slip, they'd be pickier.
All right, that should be good. I think everyone's muted now. All right, we can get back into it. Sorry about that. Okay. There we go. Okay. So with the pulp treatment, what I'm doing is simply cleaning the area of the exposure first, and it could be a small exposure, and I'll still take a cotton pellet with some sodium hypochlorite, clean the area, take a dry cotton pellet, dry the area, and then I'll use products with calcium hydroxide in it, so Theracal or even Biodentine, white MTA, and simply do a pulp cap Okay, and that's when it's a small exposure, it's clean, I've kind of controlled the bleeding. If, however, I see that the bleeding is still kind of going on, so there might be some inflamed pulp there, or the exposure was quite large, or dirty a little bit, what I will do is I'll take a sterile burr and I will perform a spheck pulpotomy. So take a sterile burr, usually I take a 330, and that's about 1.52 millimeters in depth. I will simply drop that burr into the pulp exposure, do a little circular motion, create a little circular prep. What this will do is we'll get rid of any inflamed and dirty pulp and then expose my healthy pulp, and I'll place some Theracal or Biodentin or some calcium hydroxide product in there. Following with that, I'll put a sedative dressing such as a glass ionomer Fuji material, and I will follow up. Now, with the follow-up consists the buildup with composite, but also to assess if my pulp treatment is successful. So I usually do multiple follow-ups before I do the final restoration. Again, it depends on the child. If I have a really cooperative child, I could do the buildup the next week and just monitor the tooth. If the tooth ever becomes symptomatic, at that point, I will recommend extraction, because that means our pulp cap or pulpotomy has not been successful and therefore extraction is required. All right, so discussing extraction at some point during this pulp fracture is necessary, whether it's the path you choose because of cooperation or exposure, or it ends up being a follow-up procedure that is needed because your pulp treatment is not successful. So remember that the pulp vitality has to be assessed, and the main way we check pulp vitality in primary teeth is you can do a cold test, but it's more by percussion. So percussion will tell you that the necrosis led to the abscess, and now there's might not be a clinical abscess, but we're starting to have a PA lesion develop. So sometimes we have to wait a lot longer before we can confirm necrosis and abscess and therefore recommend extraction. But I always drop the hint in the minds of the parents at the day of the trauma, as well as that first follow-up. So even though I'm doing the restorative buildup, I'll still be possibly extracting this tooth. Good. So then we go on to the next type of fracture, which has now progressed from the crown down to the root. So it goes through the crown into the root. So it is now below the gingival margin, subgingival fracture. It is pretty much a vertical fracture. The amount of crown it involves becomes important, as well as how deep below the gingiva is what becomes important. These are not good fractures in primary teeth because of restorability, as well as overall prognosis and cooperation of the child. So managing these fractures, there's pretty much not much of an option left. So this, for example, has a pulp exposure as well as a subgingival fracture. So here we see it started with the crown and is spreading subgingivally. Similarly here, crown fracture subgingivally. Now in this case, the fragment is no longer there. However, sometimes you can see the fragment is still attached. So what I do is without even touching it, I take an x-ray first. By taking the x-ray, I would see this, or even maybe more than one x-ray off angle, I would see that line of fracture going down quite deep, which most likely is subgingival. When I know it's a subgingival fracture, that means it's a crown to root fracture, I'm already thinking about extraction. I'm already starting to discuss extraction. Now, if furthermore I have a pulp exposure, the prognosis is even poorer, and therefore I'm more likely to extract as well. So I explain it to the parents in the form of, first of all, restorability. Crown root fracture in a pediatric patient is not going to be fun. Overall, its restorability is not going to be great. You're not going to be doing a gingivectomy, ostectomy, or retraction cords and of all sorts in a patient who's about 4 or 5 years old. So prognosis overall has just dropped. And then finally, if there's a pulp involvement as well, I'm not going to be trying a pulp cap with a poor restoration and then hoping that that will be successful. So extraction of the fragment as well as the tooth is recommended. We now go on to root fractures. So root fractures are fractures that are going to be all along the root. Most of them occur on the middle third, I would say, as well as the apical third of the root. And then some of them rarely will occur on the cervical third, just under the gum. So the crown looks great, but you see a fracture cervical third, middle third, or apical third. Here are some examples. Obviously, these patients will come in, they've experienced an injury, I will do my evaluation, and I will take an x-ray. When I take that x-ray, here is I would say this is more of an apical, this is getting closer to a middle third, and then these are getting more cervical and middle here. For these teeth, I've seen a difference in presentations. So these ones with the apical third, first of all, will not be very mobile, will be quite stable, might be a little tender and might be some sulcular bleeding, but not very mobile or displaced. The middle third, you have a little bit more mobility, but nothing super significant. And then finally, as you get more cervical, such as this one, you'll start to see a lot more mobility. There is a possibility of displacement as well, and a lot more symptomatic. So just in terms of prognosis, the apical third will do the best, the middle third, second best, and the cervical will do the worst. So pretty much I look at mobility. I look at mobility and I look at location of fracture. So if the fracture is more cervical and it's mobile, I'm heading towards extraction. If it's more apical and therefore more stabilized, I'm going to follow up and monitor. I do, however, get parents that still ask me to monitor the more cervical fractures. Again, for me, the deciding factor is the mobility, number one priority, because I'm worried about aspiration or choking of the fragments, of that coronal fragment, which is not going to be a great scenario. So that's the first thing I explain to them why I'm recommending extraction. And then in terms of location of fracture, that will just determine prognosis and necrosis and abscess, right? So I do explain them that aspect as well. If some parents want to monitor it for about 10 days or 2 weeks, I'm okay with pushing it if the mobility is, I would say, more stable than more mobile. Okay. Here, the last picture is they extracted the coronal segments and left behind the apical segments. That's okay. You're allowed to leave these apical segments behind. I mean, if they're that big, I always try to just scoop them out. If, however, you're unable to because of cooperation or just instrumentation and you're worried about damaging the permanent tooth buds, I'd rather you leave those behind. Keep an eye on them, explain to the parents that they might either self-resorb or they might surface as the teeth begin to erupt, and we may have to just go and grab them at a later date. Okay. So just summarizing root fracture. Root fractures are quite significant. They will be associated with some tenderness, some bleeding in the sulcus. They will be associated with some mobility. It all depends on the location of the fracture. That will determine the mobilization as well as the prognosis, and will decide for me if I'm going towards extraction or towards monitoring and follow-up. But a possible future extraction is still possible even with the ones that are having apical or middle third root fractures. Good. So those are the fractures. Now we'll go into the displacement injuries. Displacement injuries, you've probably heard the terminology. You've probably remember it from dental school. You've probably seen some of these injuries. You've managed some of these injuries. So concussion, subluxation, luxation, intrusion, extrusion, and avulsion. Okay, these are the 6 magical words. Again, these injuries don't happen on their own. You could have combined injuries, fractures, and concussions of all sorts. You always have to assess which injury is worse. So if I have a concussion with a pulp fracture, my focus is going to go towards the pulp fracture. If I have a intrusion with a enamel fracture, my injury management is going to be based on the intrusion first, and then I'll worry about the enamel fracture. So for concussion, very straightforward. You have an impact on the tooth. That tooth is now a little bit tender, but nothing significant. The patient doesn't complain too much, but a slight little sensitivity, a little weird feeling when they put their tongue on it. There's no mobility of the tooth. There's no displacement of the tooth. There's no sulcular bleeding of the tooth. You take a radiograph, you rule out any other bony fractures or tooth fractures or displacements. And what you're going to pretty much do is follow up. So post-trauma instructions, which I'll go over later, and follow up. For these type of injury, concussion injuries, I'll probably follow up. All my patients related to trauma, I follow up for the first time in about 7 to 10 days. And then after that, depending on the outcome and severity of the injury, I will decide how often I see them. So for someone like a concussion injury, they'll come in about 7 to 10 days, and I may never see them until a recall. So if they're doing fine and it's stabilizing, asymptomatic, I'm not worried about anything, I will leave it alone for a couple of months. I will still go over signs and symptoms of infections for all these injuries because you never know how the tooth will react, and therefore necrosis and abscess and extraction is always still possible. But again, in a concussion injury, the chances are very low. We then go on to subluxation. Subluxation is a little bit more of an impact. So now you have mobility of the tooth, you have no displacement, so it's just moving within the actual socket. There's no change in position or alignment. You have some sulcular bleeding and some tenderness and discomfort to the tooth. I take a radiograph, I rule out any other fractures, and I pretty much do a follow-up. So for all my subluxations, I'll do a follow-up. The only thing I have to look at for subluxation is the amount of mobility. When you have significant mobility, what you're worried about is that this will never stabilize and therefore will undergo necrosis, abscess, and require extraction. So for the ones that are severely mobile, as long as they're not an aspiration risk, I'll still follow up, but I will let the parent know that this might be heading towards extraction because stability might not come back. However, if it is an aspiration risk, I'll take it out the same day. Okay, I mean, I'll recommend to take it out the same day. Not all parents agree, and you'll see this as you see more and more trauma, that parents are hesitant towards extraction, which I'm okay with until there's an active infection or there's an aspiration risk. Those are the only two reasons where I try not to let the parents leave without making a decision towards the extraction. But again, you need their informed consent, so it is their decision at the end. Luxation injuries. Luxation injuries are where you have a displacement of the tooth. So this one becomes a little bit trickier. It's now moved into a new spot, and a lot of the times it's kind of stretched that bone as well. So it's either gone buccal or palatal. When that tooth goes buccal or palatal, it's moving the bone with it, and a lot of the times it'll get locked into that buccal plate or palatal plate. Therefore, mobility isn't always a thing on these teeth, but you can tell that they are now out of alignment. So there's different things that I look at when I look at a luxation injury. I look at the orientation of where the displacement is. Is it buccal? Is it palatal? And then the amount of displacement. With the amount of displacement, so let's start with that first. When you have a minimal displaced tooth, what I will check is, obviously with my radiograph, I will check there's no other fractures, there's no other injuries. I will then look for the occlusal interference. So if it has moved in a certain way that's causing it to interfere with the lower incisors, let's say it's the upper incisor that's injured, let's say it's interfering with a lower incisor. When I have a lower incisor interference, this will not let that tooth heal. So even if I want it to stabilize and go back, there's a constant trauma to a traumatized tooth. So your chances of stabilization or for a good prognosis, a healthy outcome, starts going down. So when you have an occlusal interference, there's two things you can do. You can either grind away a little bit of your upper incisor, your traumatized incisor, or your lower incisor to remove that occlusal interference. Or if it's a minimal displacement, you can try to reposition it with your fingers. And once it's in its new position, assess the mobility. If the mobility has not increased significantly, you just do your follow-up and let it stabilize. However, now if there's excessive displacement, so let's say it's gone completely buccal, completely palatal. At this point, the buccal one concerns me, but so does the palatal because it's going to be in crossbite with the lower incisors, and I don't want that. In general, anything that is excessive, displaced, misaligned, I will recommend towards extraction, okay? Because usually if you try to reposition these teeth that have completely... Excuse me, can you mute yourself, please?
كويس حبيبي، احنا هو في البريك بتاعنا كان بابا عمل اوردر للشيلد للفيس شيلد بابا يعني. فمن لارا.
There we go. Perfect. Sorry about that all. So going back to that idea, if it's excessively displaced, I will try to reposition, and you could try to reposition those if you have a cooperative patient. However, you'll notice that when you've displaced significantly, bringing it back, that socket is now expanded. Your tooth is not going to be very stable. It's going to be quite mobile, and therefore your prognosis drops, and therefore you're more likely to extract those teeth that are excessively displaced. So I have tried repositioning them just to see the mobility, but I've already discussed with the parents when I see an excessive displacement that we should be heading towards extraction. The last scenario is a buccal displacement. So like I was saying, there's an orientation of displacement. A palatal displacement will take the tooth into crossbite if it's significant, or it will take it into occlusal interference, which is not great. But at least when you have a palatally displaced tooth, so for example, in that image right there, where is the crown? It's oriented palatal. And where is the apex? It's buccal. Is it at risk of impinging onto my permanent tooth and damaging that permanent tooth bud? No, there's less chances. However, imagine if this crown was buccally oriented, where would that apex be? it would be palatal, and therefore it is at risk of damaging that permanent tooth bud or moving that permanent tooth bud, and therefore that's where it becomes a concern for the future. So when it's close to that permanent incisor bud, I'm not happy about that, and that's what I explained to the parents, is that yes, this tooth will be extracted today and he'll be missing a tooth, your child, but at least we're preventing damage to the permanent tooth bud. And at the end of the day, what matters to me is more the prom photo rather than the grade 6 graduation, or even before that, I would say, you know, kindergarten graduation photo, right? So what you want to do is always look out for that future, and the future outcome depends on the permanent tooth. And most parents will try to choose what is beneficial for that permanent tooth rather than the primary tooth. Most parents. So injuries, luxation, here we go. So this is a minor to moderate displacement palatally. So the crown has been moved palatally. Most likely this is going to be occlusally interfering. Most likely this is not mobile. So what I will do is I can either try to reposition it and then assess mobility, or I can remove some occlusal interference from both incisors. So it really depends on what that is. I would probably try to reposition this and assess mobility and kind of follow up. However, this one is a lot more severe. So now it has two bad factors. One is that it's quite displaced. And second of all, it's buccally displaced. So where is the root tip of this apex of this tooth? It's most likely going palatal, and therefore it's impinging on your permanent tooth. So that one is a definite extraction for me, in my eyes. Sorry about that, everyone. Okay, so that one is a definite extraction for two factors. One is the excessive displacement and the orientation of the displacement, right? So those two negatives are definite extractions. That's what I would tell the parent. If the parent wants to follow up, monitor, that is their choice, but I'm going to make sure I emphasize that this is not a good prognosis. This is not a good outcome. I recommend extraction, and it will be documented in my charts. Looking at the radiograph becomes important for these luxation injuries as well. And the reason why is by looking at the apex. So these are both luxation injuries, and both of them you can kind of differentiate where the apex is, maybe less over here, but you could over here. And that becomes important because when you do have impinging of your primary apex onto your permanent tooth bud, when you take an x-ray of the impinging, you will not be able to delineate the apex of the primary tooth from that permanent tooth. So that means you won't be able to differentiate and outline the apical area of that root because it's impinging into that follicle or that tooth bud or the actual permanent tooth. However, if it wasn't impinging, means that it's still displaced palatally, but there is still some distance, either it's buccal to the permanent or it's palatal to the permanent incisor. By keeping this and taking a 2D image, you'll still see that it's close to the permanent tooth, but you will be able to outline that apex. So if we look at this picture, the first one on top, you can outline that apex, which means good, it's not impinging. Here it's a little bit blurry, but I can still outline it. And I will show you a couple more pictures on the next two slides where you won't be able to differentiate and where you will be. So I want you guys all to really be able to see that, because that is a huge deciding factor on where that apex is and will it be at risk of damaging the permanent tooth, so that you can provide this information to the parents and then they can make the decision whether they want to risk it or not by leaving the tooth in or by taking out. So the next two injuries, intrusion, extrusion. I'll start with extrusion first. It's quite simple, quite easy. The tooth has kind of popped out of its socket. You take a radiograph and you see that now there is an apical space, apical to the actual root tip. And what this means is that it's came out of its socket a little bit. Now, if it's a minor extrusion and the tooth is quite, let's say, open apex, immature, I'll simply just push it back in. And then I'll do my follow-up. I will let the parents know that this may or may not work. We'll do our follow-ups. If ever it has signs and symptoms of infection, we'll have to extract it. If, however, it is a moderate or severe extrusion, I'm most likely looking at just helping that tooth come out and extracting it the day of the trauma. In terms of intrusion, these are a little bit trickier. So when you have an intrusion, your tooth goes up into the socket. And what you want to do is take a radiograph, obviously, to rule out any other injuries, but you're going to do something else with the radiograph. And I'll tell that in the next slide. What you want to do before you even look at the radiograph is look at the type of intrusion. So was it a straight intrusion? If it's a straight intrusion, that means my apical area of that root is probably not damaging my permanent tooth. But if that intrusion happened with the crown going buccal, again, now my apex will be palatal, which is not good. Okay, so the only intrusions that I like to take out the same day are the ones that are damaging that permanent tooth or at risk of damaging the permanent tooth and are severely intruded. So a little bit intrusion palatally is not going to bother me, but a severe intrusion with palatal apex, definitely coming out the same day. Minor intrusions, moderate intrusions, straight intrusions, most of the times I let the intrusions self-erupt. So parents are usually on board with that as well. We keep an eye on them. I tell them the follow-up is absolutely important for me to monitor the progress in the eruption. So they do have to come back for those. There is a risk of ankylosis of the tooth now that it's been intruded. There is a risk of damage to the permanent tooth still. And last but not least, there's a risk of necrosis. So signs and symptoms of infection are explained. We do the follow-up. I usually do a follow-up again, 7 to 10 days. And then after that, a month later, 2 months later, and 3 months later. I've done it up to 3 months, and you'd be surprised. I've seen a couple of intrusions that were very severe, but straight. I could maybe see half of the crown above the gum, or even less than half the crown above the gum. So it was very intruded, and 1 month follow-up, no progress. 2 month follow-up, a little progress. We go over Christmas. Now it's been 3 months since the trauma. They come back for their follow-up. I'm preparing for extraction because I've given it my 3-month limit, and the tooth is magically there. It's back into its normal position. It has stabilized. At this point, I know it's not ankylosed, but I still warn the parents of possible signs and symptoms of infection and possible future extraction. But it's looking good right now, and the parents are happy. So I usually follow up intrusions up to 3 months, other than the ones that are severely intruded and are palatally intruded. Those ones I'm either extracting the same day or as soon as possible, as soon as the parents are ready. So we'll go over the x-rays for the intrusion together. I'm going to show you the outlines of the apex, but let's just look at the extrusions real quickly. So for extrusion, like I said, this is a quite severe extrusion. This kid is a little bit older because he has his lower incisor coming in. So these might have already been resorbing and mobile. And now they've just kind of extruded completely, if not completely, at least 3/4 of the way out of the socket. So these are going to be extremely loose. I'm not pushing these back in and hoping they stabilize because they won't. I'm extracting those. And the x-ray shows that, yes, this one right here may have had a little root fracture, a little tip left behind, but there's not much root left. Its orientation is also changed. It's extruded. I'm taking this out. Similarly here, root fracture, that's the importance of the x-ray as well. That root fracture you can leave behind, and then this right here you will take out because it's hanging and mobile. Now we go into the intrusion. So intrusions are tricky, challenging, and fun. They have been intruded. So this tooth has been intruded, and when I took the x-ray, I can see that it's no longer in alignment with the other central incisor, so it has been intruded as well. But let's go do the apical part. So it looks like the crown is coronal, which means the root is apical, but it's not significant. So when I look at the x-ray, I can clearly identify the whole apex. I can see the lamina dura, I can see the PDL space, I see the full apex, and I see that the crown is fully visible. So there is superimposition, but there is a gap between the teeth, and therefore there's no impinging. I'm okay with monitoring and following up that intrusion. However, on the other hand, if you look at this one, so these are 2 different scenarios as well. We'll start with this one first. It has been intruded. You can clearly see the difference in height. It's intruded, maybe, let's say clinically we see it. It's kind of oriented a little bit buccal. I'm not sure. I take an x-ray. I can still pretty much delineate the apex. A little less clear than this, but I can still outline, and I do see a tiny little space of PDL space. So I'm not loving this scenario as much as this one, but I'm still okay, comfortable with letting it spontaneously erupt. Still telling the parents there is risks of damage to the permanent tooth and changes in the permanent tooth, but it's not clear. It's their choice. If they want to take no precautions, we can extract it. If they are okay with taking that little risk, I'm okay with leaving this in. This, however, I know there's an apex because I can see the continuation on the other side. However, when that permanent tooth crown comes, I absolutely see no roots. I cannot delineate that apex. There's no signs of infection or resorption, so it's not like it was resorbing. I cannot clearly delineate that apical roots, and therefore this intrusion is most likely going right into that permanent tooth bud, and therefore this is the one I would extract the same day. And you can tell it's a much more severe intrusion than either of these. So I hope that's clear. That's the approach I use for palatal luxations as well. So when you have the roots going palatally and the crown going buccally, you use the same idea of evaluation of your x-ray. And this is a great trick to just be able to know, hey, is there any risks for damage to my permanent tooth? Okay, and now you all know it as well. Avulsions. So primary teeth are never reimplanted. So I don't know if you've ever reimplanted a primary tooth. I hope not. And if you have, I hope the outcome was okay. In my training, as well as all my colleagues, as well as what we read in the guidelines of pediatric dentistry, a primary tooth should be never reimplanted. You will occasionally have parents that will come in with the primary tooth in either milk, in a Ziploc bag, in water, in whatever, and they're saying, please implant this back. I had a patient where the child was about, I think, 2 years old, avulsion, and the parent absolutely wanted that primary tooth back in, and splinted and whatever. They had done some reading online, and they said, oh yeah, you're gonna put it back in, and you're gonna put a metal wire, first of all, on a 2-year-old. Second of all, it was a primary tooth. So I think they stayed in the office for about 30, 45 minutes, an hour. The explanation that I had to give them took about 10 minutes. Them trying to convince me to reimplant this tooth took the additional 45 minutes. So I still didn't do it. I told them why I wouldn't do it, and I'll tell you all as well. But what you have to remember is don't be forced into doing something that doesn't make sense, okay? So you see the socket right here. So I still take an x-ray on the avulsion. I check the socket, and when I check the socket, I see that there's no fragments left. By the way, these two are not the same case, but what I wanted to show you was the socket is void. Maybe there's a little piece of a root left here, or it could just be the shadow of the image of the socket. You want to make sure there's nothing that you can retrieve from there, or nothing that's bony fracture, and that's what you're confirming. Now, this also helps you show the parents that why I can't put the tooth back in. So the reason why I don't put the tooth back in is that when I'm putting that primary tooth back in, I may, just by replacing that primary tooth, I may damage the successor. Just by pushing that primary tooth in, I might impinge it onto a permanent tooth. I might displace that permanent tooth. I might push it into the follicle of the permanent tooth, and therefore cause abnormal development of that permanent tooth. So that's number one. Number two, as I'm putting this primary tooth in, avulsions in general have terminated their vascular supply to that tooth, and therefore when I'm going to put in an avulsion tooth, what you will see is there's a high risk of necrosis, and that's what we'll see in the permanent dentition as well. But in the primary dentition, just as much, there's a risk of necrosis, and therefore when you get necrosis of that primary tooth, I will get an abscess. That abscess on the primary tooth will require extraction of the primary tooth, but by leaving an abscess around, you're also damaging your permanent successor. So risk of infection as well as damage to the successor. So now we got, again, 2 factors. Last but not least, replacing an avulsion tooth ends up with a risk of ankylosis, and the risk of ankylosis is higher when the apex is closed. So these are my 3 factors. If I have ankylosis, what's going to happen to my permanent successor? It's going to either ectopically erupt or never erupt, which means I'm messing the successor. Simply placing the tooth back into the socket, you can damage your successor. And lastly, causing a primary tooth infection can also have consequences on your successor. So everything you're doing is bad for the primary tooth, other than the aesthetic appearance. That's what you tell the parents. But you're also going to be putting huge risks on your adult permanent successor. So they need to know that. They're thinking about appearance. They're thinking about what the child will feel, how the child will eat, but there's a lot more that goes into it. So explaining them that and educating them on that takes about 10-15 minutes, showing them that with the pictures. But like I said, you may have a parent that sticks around for another 30 minutes trying to convince you to reimplant a primary tooth, but I will not do that ever. Haven't yet and don't intend to. So what are our future outcomes, things that you should discuss with parents? So remember that when you have a primary tooth that undergoes traumatic injuries, the more severe the traumatic injury, the tooth is always at risk of necrosis and infection. So this means the pulp fractures, even the dentinal fractures sometimes, as well as all the displacement injuries. They are always going to be at risk because they've been traumatized. You may have disrupted the vascular supply, and now you're at risk of necrosis as well as infection of the primary tooth. In general, open apex teeth, which are immature teeth and still developing with a large opening, large vascular supply coming in, generally have a better prognosis. When you do see a grayish tooth color, which a discoloration is possible on primary traumatized teeth, for an adult tooth, you would think about endo. For a primary tooth, I would think about nothing. I would do follow-up and monitor. I would tell the parents that this is known as aseptic necrosis. There's no cavity, there's no bacteria, there's no pathogen. What it simply is that the tooth has died and has necrosed because of the traumatic injury. So all we have to do now is monitor any signs and symptoms of infection. So abscesses, pain, any enlargement of the area, facial swelling. These are the things I tell them. And I tell them that by having this, not only do we have to take the tooth out to let that area heal, but by leaving infections around, you're at risk of damaging your permanent teeth. So what are the risks of damages to your permanent teeth? They can experience discoloration, such as this permanent incisor. They can have enamel defects, okay? So you can have defects or malformations of your permanent teeth because they were undergoing development when this trauma happened. Similarly, if you have ankylosis or impinging, you can also cause eruption patterns to change. So ectopic eruption, delayed eruption, these are all possible outcomes for your permanent teeth as well. So educating the parents on these topics is really necessary to make sure they make the right decision for their child. Post-trauma instructions. So these are the basic post-trauma instructions I give to all patients. First and foremost, follow-up and monitoring is absolutely important. So I go over signs and symptoms of infection. I really describe it. I show them what an abscess looks like. And I tell them why I'm doing the follow-up. I'm doing the follow-up to check for vitality and necrosis. I'm checking stability, mobilization, risk of aspiration, pain. That's the reason why. And to prevent damage to your permanent successors. I go over soft diet. I usually recommend, depending on the severity of the injury, anywhere between 1 to 2 weeks of soft diet. So that means mushier food, no crunchy apples to bite into, no carrots to bite into, no granola bars to bite into with those front incisors usually. And then I go over hygiene. So hygiene should be more likely for primary dentition, supervised by the parent. They should be gently brushing in the area of the trauma. They should be doing circular brushing twice, 3 times a day. If there's lacerations of the gum or severe injuries in that area, I may even recommend some chlorhexidine rinse for the older kids. For the younger kids, you can always take a Q-tip, dip it in chlorhexidine, and simply gently rub on the area of laceration or the area of gingival inflammation and irritation. So that is possible for them as well. I do recommend no contact sports or physical activities for about 2 weeks, letting this stabilize. Any succedaneous injury to this tooth could cause more and more worsening of the prognosis. So that's what's really important for them to understand. And last but not least, analgesics as needed. So Advil, Tylenol, and Motrin just as needed for the child to get through the pain, usually about the first few days. And then after that, it gets a lot better. In conclusion, so that's it for the primary dentition. In conclusion, remember, clinical evaluation, radiographic evaluation becomes really important. You want to assess extraoral injuries, soft tissue injuries. If there's lacerations that are there and there's fragments of teeth missing, check those soft tissue areas, palpate them, take a radiograph of a soft tissue area to make sure a fragment hasn't gotten stuck into the lip or the cheek. You also want to be looking for multiple dental injuries on one tooth. You want to take pre-op radiographs always, photographs as necessary to document and to watch the prognosis and healing of this patient. Remember that future outcomes are necrosis of the tooth, abscess of the tooth, root resorption of those primary teeth, but also you're looking out for mobility and how it's stabilizing. The more mobile the tooth is, the higher the risk of aspiration. More mobile the tooth is, it also has decreased prognosis for survival of the tooth, which results in risks of abscess and therefore resorption. Remember to also go over future consequences to the permanent tooth, to the bone, to the position, the eruption patterns, as well as risks of abscess and aspiration to the tooth that has been traumatized. That covers everything. So that is it for the primary dentition. I hope it is a lot clearer for everyone, and I hope it was a refresher for those who have already known this. I want to thank you all for joining. I just want to remind you that all my information is taken from the AAPD guidelines, the International Association of Dental Trauma. So that is a very good website for all your dental trauma information, primary or permanent. The Dental Trauma Guide is a resource that you can, I think, subscribe into, purchase into, and it has photographic images of each of the trauma, their prognosis, their outcomes, as well as their management. My gift to you is this app right here. I'm pretty sure it might be on Androids, but I know it's on iPhones for sure, iPads as well. It's called Tooth SOS. If you don't already have this, it's a great discovery that I made at a past dental conference. And it is an amazing app that has two interfaces, one for healthcare professionals, so to guide you and to manage the actual trauma, but then also a parent interface, a patient interface. And that patient interface, what it means is it actually guides the patient and the parent on how to manage this dental injury. Okay, so definitely check that out. I think you'll all enjoy that. Webinars will be available for the recorded versions real soon. I'm working on that. An email will be sent out to all those who attended with a survey and feedback. So please definitely do that for me. That would be great.